All right. So hi everybody. I'm Kyle Gray. I'm still currently a fourth year resident at Walter Reed, graduating in 7 days. So this is the first iteration of a recorded Seven West orientation inspired by a video that Dr. Amin did for his addictions rotation at Belvoir that Ton and other interns found very helpful. So we're trying to do that same sort of thing for Seven West. So this orientation has been a collection of wisdom from all the NCC psychiatry residents that we've come into contact with and collected by myself and Ton and put together for you guys today. So again, this orientation is not going to be exhaustive. And in keeping with our residency culture, especially now, we encourage feedback and innovation about this orientation to make it better. Hopefully this orientation will be edited and made better and that sort of thing, and you guys can help us do that. So we purposely didn't want to cover too much, but we wanted to cover the basics and the most critical parts of this rotation. So we're going to start with the expectations for the rotation. Then we're going to talk about things that you should do before you start the rotation to help yourself be a better team player, to be ready to jump right into things. And then we'll talk about some highlights of your role and responsibilities, and that will include the daily rhythm of Seven West, and also how to battle this feeling of disorientation and feeling overwhelmed that can happen with Seven West. We'll talk about a little bit. And then we'll talk a little bit about how to navigate your resources, because even that can kind of be overwhelming, but we're hoping that this whole effort is going to make that process a lot easier for you. So starting with expectations, you're going to learn a lot of meat and potatoes military psychiatry on this rotation. And hopefully that means you're going to have a lot of fun. And speaking of fun, we're going to frame these expectations in ACGME milestones, because that's really ultimately what we're working towards, is for you to develop all of these milestones for yourself as a psychiatrist. So starting with practice-based learning and improvement. So one of the things you really want to try and do on this rotation is improve your own workflow. So what's going to help with that is to review everything in the Seven West orientation document. And that's a document I'm going to be referring to a lot in this orientation video. And so hopefully you have that available to you. And one of the things we've tried to do is make it that much more organized and navigable. So you can even do things like, control click on the table of contents to jump around as you need. But basically what's going to help you improve your workflow is knowing that document, knowing your roles and responsibilities, and we're going to, like I said, highlight those here. Things like utilizing checklists for yourself daily and using discharge checklists, and all of those tools can be found on Sakai and on the SharePoint site as well. Those are going to help improve your workflow. Giving and receiving appropriate and actionable feedback is also a big part of practice-based learning and improvement, and something that you'll be doing daily on this rotation. And developing this skill in self-evaluation and evaluations of others is a huge part of what you're learning throughout residency. Also, responding to feedback from your patients is an important skill, and something for you to be paying attention to. For patient care and procedural skills, so one of the biggest things to develop on this rotation, again, is that another skill of taking patient ownership. So you want to take ownership of your patient's entire treatment plan, including everything from medication management to bibliotherapy, assigning them particular therapy worksheets that are appropriate for them, that sort of thing. And then even directing what kinds of groups they will attend while they're on Seven West. And you can talk with the nurses and social workers about that. And you can read in the Seven West orientation, what's it called? the Seven West orientation document, the section on Seven West groups and milieu activities. That can help you think about what groups your patient's going to be appropriate for. Also, especially taking ownership of your patient's dispo planning is a big part of that. And you'll be working with your supervisors and other members of your team as appropriate along the way for all of that. Procedural skills. So a lot of people think that isn't really applicable to psychiatry, but you can also think of therapy as a procedure. And Seven West does give you a chance to develop those skills. And you can start to read the workbooks along with your patients, kind of do them along with them. And again, it's kind of your first chance to really start to develop those skills. The ones will also have an opportunity on weekends when they're on call to run doctors groups. There should be guidance for you for that as well. So make sure you're talking to people about getting guidance for that. Twos, you'll be doing interpersonal groups for the first time on the ward. You should be getting didactics about that, and you can read YALM. Make sure you get feedback for that. Also, what falls in this category is knowing when and how to use specific exams like the MOCA, the AIMS if your patients are on antipsychotics, how to go through a CAMS with your patient, and then there's a special section on CAMS in the orientation packet. All right, systems-based practice. Big part of that is anticipating your patient's need. For example, does your patient have a substance use problem? And what level of treatment would they need to address it? So thinking about those kind of things. And when you're thinking about it, did you put in the appropriate consult in the system? And did you actually consult the residential treatment facility if you're thinking they needed that level of care? Those kind of things are all about systems-based practice. Another example is an example that I think really teaches you all. It's a great lesson in systems-based practice is learning how to arrange a medevac. God help you if you have to learn how to do that, but if you can do that, you get a gold star in systems-based practice. Also in this category, consulting colleagues. So, understanding, for example, when is psych testing appropriate? Who are the people to contact? How does that work? Also practice differentiating which problems your patients have that might necessitate an inpatient versus an outpatient consult. So for example, if pain is one of your patient's biggest problems, is it an acute issue? Is it something that's driving their suicidality that it would be helpful to have an inpatient consult versus more of a chronic outpatient issue? And practicing how best to present the patient to your colleagues is all part of this milestone. So for medical knowledge, basically on this rotation, the biggest emphasis is to focus on learning about your patient's specific problems, and that's what's going to develop your medical knowledge the most. So if your patient has MDD, knowing how the ins and outs of that, the medication options, that sort of thing. And then also what we'll go through towards the end of this presentation is a recommended light curriculum to help you, again, to learn some of these core basic things as far as medical knowledge and to do all in this rotation. For interpersonal and communication skills, for this bullet, I borrowed the language exactly as Dr. Amin had written it in his presentation like this, that basically your relationship with the staff, having effective communication with the staff and peers and command to improve inpatient outcomes. So what does that look like? So for example, did you invite the nurse and the tech into the treatment planning committee meetings or conference meetings on Mondays and Thursdays that happen on the ward? They're commonly left out, but if you do that kind of thing, that's showing that you have good interpersonal and communication skills. Did you cut off the lower level trainee during their interview and take it over prematurely? Maybe that's something you need to work on. Do you understand the roles of the treatment team members, and do you appropriately and tactfully delegate all the tasks that need to be done? And again, I want to reference the orientation document that goes through it has a section on the 7 West staff and their roles. So lastly, professionalism. Basically what I want to say with that is if you do all the above steps, you're going to be able to manage your time better. You're going to be able to do things like be on time and balance your life and your work better, be able to meet your personal needs and your patient care needs. So if you do the above steps, professionalism should kind of fall into place. Also, though, it's important to recognize that in psychiatry there are inherent ethical dilemmas, and being able to work through these with the appropriate consultation also is an important skill and develops your professionalism in this area. All right, so the next thing we want to talk about is, and this is kind of a new section, but what we found to be very important to help things run more smoothly on 7 West, or we're hoping is gonna help things run more smoothly, is things for you to do before day one of your rotation. This is going to help you be a good team player, not be the weak link on the team. So again, see the orientation document for detailed steps for all of these, and we're just going to hit some of the highlights of these steps, particularly the first 2 items here, because they're a little more involved and the most important. So the first thing is to get access to the Army e-profile system. I'll explain why that's important. Same thing, the next step is to get access for essentially the Navy parallel to the e-profile system, the LIMDU SMART system. So I'll talk about a little bit the nuances of that. And then the third thing is to request access to the non-formulary drug request, I think is what R stands for, system, but NFDR system. And the steps for that are detailed in the orientation packet, but just know that that's something you should do too, because some of your patients will come in on medications that aren't in the Walter Reed formulary, and the process goes much more quickly if you are in that system, because you have to actually request for the pharmacy to get that medication if it's not in the formulary. So it's good to have access to that. Okay, so the first thing for getting access to e-profile, just going through the steps quickly, the first step is to go to JKO and take this course, the 298 Medical Readiness Healthcare Portal Training. They say it takes about an hour and a half. I don't think it practically takes that long, but I just wanted to show here the screenshot because I think JKO is a little bit clunky to use. But you go to JKO, you go to course catalog, and in that little weird search bar up here, you search for 298, and then this is what it looks like. So you click launch. And there's a direct link to the course as well in the orientation packet. And then after you do that, then you request access via MODS user management. Again, that step is detailed more in the orientation packet. I wanted to show just this screenshot because the weirdest part of that process is this assigning your property assignment. So the first thing is to know this is our property, Bethesda PDMIS 0067. So you click that. You click this arrow and then you save property assignments. So that's to get assigned to Walter Reed. And then you email your mods. Mods should then generate an email, which you'll email to Donnie Nieves, along with a copy of your JKO certificate, just in case for whatever reason that didn't get sent to mods, and send also your DOD ID. You send all those things to Donnie, and you should be able to get access. Donnie is your POC for this. So again, just those 3 steps to get access. It can take some time, so please do try and do that before your first day. And why do you need to do it? Because Army regs dictate that all Army soldiers need at least a 30-day temporary profile prior to hospital discharge for all inpatient psychiatric hospitalization. So this is just a screenshot of this policy from MedCom 17-TAC-079 in the second enclosure. So that is a part of Army regulation. How do you put in an Army e-profile? You might know him. Dr. Amin made a wonderful step-by-step video about how to put in an Army profile. It's about 10 minutes in length, and the direct link is in the orientation packet. I feel like a broken record saying that. And also just to be aware of, the Army e-profile system does have templated language for behavioral health profiles, which is very helpful. Just be sure to go through it and edit it as appropriate. So then LIMDO Smart for the Navy folks. So these are the 3 steps to get access to that system. Basically, you go to Walter Reed's Relias Health system and you take fortunately it's only about a 7-minute training for that. And then you get a certificate, you email that, this is the second step, to Beverly Mitchell, and there's her email address with your DoD ID and your discipline, physician or resident or whatever. And then once you have access, you can log in. So make sure you check that you can log in. Importantly for LIMDO, these are kind of like hidden tips. Using Chrome is much better than Internet Explorer for that system for whatever reason. Also, you need to choose your email certificate for your CAC login. So make sure you're clicking that instead of like the regular one. If you have any issues, the LIMDO Smart Desk is actually really helpful. Okay, and then just some considerations for Navy medical readiness. So just wanted to note that the Navy does not have an equivalent to MedCom 17-TAC-079. So hospitalization does not mandate a light duty CHIT or LIMDO. However, it's important to understand that every behavioral health clinical encounter with a sailor or Marine and any service member should include an assessment of medical readiness and deployability to austere environments from a behavioral health perspective. So the reasoning behind MedCom 17-TAC-079 still applies. So an inpatient hospitalization by definition means someone's had a sort of major behavioral health destabilization and would require a higher level of oversight once they're discharged, and the 30 days after hospitalization have a known higher mortality risk. So most likely you're thinking about LIMDO versus light duty CHIT. So what are those briefly? So light duty basically presumes frequent provider and patient interaction to determine whether return to full duty status or more intensive therapeutic intervention is appropriate in any given case. So therefore, these CHITs are really not to exceed 30 days. So let me start that over, Ton. Edit this out a little bit, but importantly, light duty CHITs are not to exceed 30 days to ensure that the patient achieves or that the patient has appropriate clinical oversight. So there can be consecutive light duty CHITs for any new condition if after that 30 days lapses, and that can happen up to 90 days. In maximum 30-day periods, but in no case will light duty ever exceed 90 consecutive days, inclusive of convalescent leave. And so light duty can be considered when adjusting medications that are not deployment limiting, and to see what those medications are. So generally like mood stabilizers, benzos, antipsychotics, refer to MOD 13 regulations. So light duty can be considered if if your patient doesn't have any of those meds or during an acute time-limited increase in symptoms. If your patient is on any of those deployment-limiting medications, they would need to be on a LIMDO. So what is LIMDO? The assignment of a member to a duty status for a specified time with certain medical limitations and restrictions concerning the duties the member may perform. So basically, again, the same thing kind of as a profile, but for our Navy personnel, the time limitations are a little bit different. But for LMDU, it's expected that the sailor or Marine would be expected to be able to return to duty in a reasonable period of time that is greater than 30 days. So again, for less than 30 days, you're thinking more like a light duty chit. And the LMDU periods, when you initiate them, they happen in increments of 6 months, and they have a 12-month maximum. So basically, people can have essentially 2 LMDUs, so long as the LMDU period was, total. Both LMDU periods were 6 months total. So that's why we need to be thoughtful about when we initiate LMDUs and when we remove them. And for outpatient providers, they should be assessing if a person still needs to be on LMDU at every visit. And so for this definition of return to duty, if at the completion of the period of LMDU or at any time during the LMDU period, a sailor or Marine is determined to be fit for full duty, then a return to duty form must be completed in the Smart LMDU portal. And that's signed by one provider and then the convenient authority. So I just highlight that to note that if you put someone on LMDU because you think they need to be on LMDU, they shouldn't be deployed, or they're on deployment limiting medication, that kind of thing. Just know that it doesn't necessarily mean that they'll be on LMDU for 6 months. They can be returned to duty sooner if that's appropriate. But our sailors and Marines are concerned about it because, again, they can only get really 2 of those LMDUs before they would be evaluated by a medical board. So, as I mentioned, the eProfile system has some templated language, and that's kind of nice. The Smart LMDU system does not have that templated language, so I just wanted to highlight some of the appropriate and inappropriate functional limitations to put on things like a light duty chit or a LMDU. So the basic thing to keep in mind here is that overly restrictive profiles hinder a commander's ability to keep a service member engaged in some occupational function within the unit and could exacerbate isolation from helpful peer support. So things to avoid that type of thing are no 24-hour duty, no rotating shifts, no formations, no uniforms, those kind of things. As you can see on those examples, avoid using those kinds of phrases. Things that are appropriate, so these are the type of things you actually see in eProfile templated language. No deployment, requires 8 consecutive hours of sleep in a 24-hour period. No alcohol, no weapons, those kind of things. So you can take a look at this slide if you need some references. Okay, so this slide is all about your roles and responsibilities and kind of the day-to-day flow of 7 West. It's titled Aim to be a Zero because that was kind of my guiding principle that I used in residency that basically said my main aim is to be competent in the things I really need to know how to do. So that's essentially what it means. It's from Canadian astronaut Chris Hadfield, if you're interested. Anyway, so your day-to-day schedule may vary some according to your attending and your team size and the team's patient load. So for example, if your team has 6 or more patients and a busy day ahead, your patient schedule might change some. Actually, Ton, if you want to edit that part out, I jumped ahead a little bit too quickly. I'll get back into that. Okay. So to start off, before morning sign out at 7:30, you want to get in and review your patient's charts, including their vitals and nursing notes, sleep notes, that kind of thing, before morning report. And you want to copy forward the multi-D note for today. The reasoning for that is the multi-D note is something that not just physicians use, but also nurses, techs, social workers should be editing that note. So they need to have access to that note, and they might work on their note before you work on it. So it's important to have that note open as early as possible. 7:30 is morning report, so be on time for that. You'll hear kind of the nursing sign out as well as the POD sign out. And then after morning report, that's when your day-to-day schedule may vary some according to your attending, according to your team size, how many trainees you have, as well as your team's patient load. So, for example, if your team has 6 or more patients and a busy day ahead, it's a Wednesday, you have didactics or whatever, you may try and see your patients on your own and discuss it with your attending afterward. But if your team's really small and your attending may prefer for all of you all to see your patients together as a team so that people can observe others in reviews and learn that way. So again, it might just depend a little bit on those circumstances, what happens after morning report. But basically, you're going to huddle with your team, go over how you want that to look, and see your patients in some fashion. And on Mondays and Thursdays, you will be seeing your patients with the entire treatment team, meaning also the social workers, the techs, the nurse assigned to that patient. After that, then if you saw your patient alone, then you check in with your attending, and then prioritize writing orders and communicating those with the nurses, whoever it needs to be communicated with. During this time, you might also have command meetings. And command meetings, we want to try and have a little bit more guidance about that as well. But essentially, command meetings are time to get collateral about your patient and to share the elements of your patient's information with command according to the DoD instruction 6490.08, which is an instruction you should familiarize yourself with. If you also look at the patient confidentiality section in the orientation packet, it goes through all those things. So that's kind of what command meetings are for, and each active duty patient will have at least one command meeting during their hospitalization. This might also be a time for teaching, so try to ask for specific teaching that you want on this rotation and come up with learning goals for yourself, and work to teach med students and other trainees as well, because teaching can be one of the best ways you learn. You won't feel like you know enough, but that is how you learn and grow. So give it a shot and you'll probably surprise yourself. Okay, then after that, lunch, I put that in there intentionally. Probably one of the most important learning points of this presentation is a reminder to get Caribbean Bar on Fridays. Hopefully that never changes. Do try to take a real lunch break for yourself and spend some time in the healing garden with friends or whatever, not just shoving food in your mouth in front of the computer, is highly recommended, but also, you do you as well. Okay, then after lunch is a time for finishing notes. It may also be a time that you have an admission. So early afternoon and late mornings are probably the most likely time that you would get any new admits during the day on 7 West. Most of the time, these patients will have been seen by PCLS, and there should be a note in there, but they might be an outside transfer, and you might not have a whole lot of documentation to work from. But most of the time, you can do more of a focused clinical interview if you're seeing a patient during the day, a new patient during the day. And you can see the orientation guide again for details about new admissions and that sort of process. But one thing we wanted to highlight here was to remember that if the patient has any established outpatient behavioral health providers, be sure to reach out to them early in the patient's course. For things like if a patient was admitted for the second time because they weren't adherent to their antipsychotics, talking with that outpatient provider about what do you think about a long-acting injectable for this patient, working through those kind of things. And also just seeing how they see the patient. It really, really does help, and it'll help you to feel more connected with the system. So this time's also good, again, to, like I said, finish notes, but also tee up discharges, especially for the next day, having everything ready, like the 3822, the medications and CHCS, all of that kind of stuff is important to be working on during this time. During this time, twos will also have their interpersonal groups Friday afternoons, and you can see more guidance about that on this orientation website and the share drive. Let's see. Yeah. And then at 1500 is when we recommend that you really start thinking about sign out, update sign out on the Walter Reed Intranet DBH SharePoint. So that's another good thing to make sure you have access to before you start the rotation. And then at 1530 is sign out in the same room as in the morning, and remember that you should be prepared to sign your patients out in an iPass format. Okay, so we wanted to talk a little bit about what we're terming disorientation syndrome on 7 West, and I think we're highlighting some of the main contributors to that. So basically, what this means is a lot of times when interns and even residents that come back to 7 West feel disoriented when they come on because it's so different from medicine and other things that they're used to. I think there's two main contributors to that. Number one, there's a much higher focus on readiness and administrative work that we didn't learn in med school. So a lot of this is new stuff to us. So learning a whole new system on top of trying to learn psychiatry. And then the second thing is the treatment planning itself is very different. And Ton and I plan to have a separate section on this website dedicated to, we'll have a video up that goes over in more detail what treatment planning, good treatment planning on 7 West. Or basically any inpatient ward looks like. But essentially that means it's multidisciplinary, it's has SMART goals, that kind of thing. But it looks very different than what treatment planning might look like on 5 Center, for instance. Also contributing to this whole problem is that there's oftentimes rotating attendings on 7 West. There's kind of a revolving door at times, unfortunately. That's just reality with the way things work in military medicine these days. And so there's a lack of institutional knowledge. So that's why, again, we're hoping that this sort of orientation video helps be a remedy to that issue. And then the third big contributor is simply fatigue. So this can be one of the most tiring rotations that you have as a 1 or 2, and you're frequently on call. So I think the number one message here is to remember that you're never alone in this, and to not ever hesitate to reach out to your peers and especially to the chief residents if you're especially to reach out to the chief residents if you're starting to feel that fatigue is really starting to affect you. I've had, many peers do that kind of thing, and it's always been a positive experience for them. The other thing is just to know that while you'll be working hard these months, that hopefully this will be fulfilling for you, and this is really when you're going to be learning the most about your job, what you're doing as a military psychiatry, and that it's going to feel like a lot at first, but it will get easier. And it's a residency long process. Okay. So again, kind of with that whole aim to be a zero mentality, this is again a little bit of a new element to this, but we have a recommended, again, very light curriculum and just some words about navigating resources. So we hope that this curriculum will help you feel more comfortable with things you'll be dealing with every day on the ward, and potential emergent situations. So for week 1, really the main thing is just to read the entire 7 West orientation packet. It's kind of long. It's like maybe 40 some pages. It's information dense. So really but actually reading through that is very helpful. And then there's kind of a lot of information about treatment planning, but there's one very high yield article that we recommend you read in the first week as well. It's a super old article written by a nurse, and so I know some of that might be triggering, but truly I found it to be the most straightforward, the most common sense. It made the most sense to me as to why we do things this way. So in week 1, we recommend you do those readings. And we'll have all of this, like week 1, week 2, week 3, week 4, available on the website. For week 2, the focus there was operational psychiatry. There's, again, a ton of materials that you can kind of overwhelm yourself with here. So we wanted to really focus in on the highest yield resources. So just to know is that on this website and in the share drive under operational psychiatry resources, there are a lot of resources there, and Dr. Tucoletto is sort of the main guru about operational psychiatry who created a lot of those resources. So if you look for the Tucoletto folders on the share drive, that's where you're going to find a lot of these. The two from that we wanted to focus on is there's a resident guide, and then there's a quote must know for military psychiatry document. Those aren't too long, but if you try and get through those in your second week, then you're going to feel a lot more comfortable with what you're doing on 7 West and what you're hearing about Admin SEP and what you're hearing about MedBoard and that kind of thing. And then weeks 3 and 4 focus on kind of the primary reasons that people would be hospitalized. So week 3, we're going to have some readings that focus on managing suicidal patients, especially suicidal patients on 7 West, and kind of things we can do on the ward to help with that. And then week 4, managing emergent situations, like if you need to use restraints, and how to manage aggressive patients and that kind of thing, so you can feel more comfortable with those scenarios. And then since we spend more time than just 4 weeks on 7 West during our residency, we'll also have some folders on this website with additional resources for self-directed learning. And as part of that, I do highly recommend you take a look at workbooks that we have available for you to use with your patients. All right, thanks. So if you have any feedback for this, again, you can reach out to Ton, who will be updating this website, and I also appreciate feedback. So good luck and have fun, and always remember to be a good teammate, be a good friend. I think that's kind of one of the main things to focus on in residency. All right, thanks everyone.